So this discussion is going to be about pancreatitis. This is going to be a good video for 3rd and 4th year medical school. It's going to be a great video for GI rotation or internal med rotation. So let's talk about the basics of pancreatitis. Now, first off, how is it going to present? Well, you're going to see a patient in acute pain. Where's that pain going to be? It's going to be in the epigastric region. So you're going to see epigastric pain. You're also going to see that epigastric pain radiate to the back. That's going to be a trademark of pancreatitis. You're going to see a patient that comes in with an acute epigastric pain, and they're going to say, well, does the pain refer anywhere? And then the patient's going to say, well, yeah, it kind of goes to the back, or I have long-standing back aches from this disease. Also going to present with severe nausea and vomiting. Pancreatitis, it's not just going to be one flare-up, it's going to be hours of prolonged nausea and vomiting. There's a couple clinical cues, skin changes. You've got gray Turner sign, and you've got Cullen's sign. Gray Turner sign is going to be flank discoloration. So you may ask the patient, can I have you turn to your side and then lift up their gown and take a look. If they have discoloration on their flank, you need to be thinking, oh, is this a case of pancreatitis? No, having a gray or a darker skin change on their side does not mean that the patient is going to have pancreatitis. However, yet with a clinical presentation, you could be starting to think pancreatitis. Cullen sign is going to be a periumbilical discoloration, like a grayish discoloration around the umbilicus. So there's some good heads up. I know there's a lot more. You could have hypoactive bowels. You could have severe fever, depending on how the extent of the pancreatitis, the inflammation of the pancreatitis. Let's take a look at lab values. So labs, you've got two main labs that I want you to consider. So we're going to be looking at the exocrine function. So the pancreas, it has an endocrine and an exocrine function to it. We're going to be taking a look in a patient with pancreatitis. We're going to take a look at their exocrine. And more specifically, there's two enzymes. There's going to be amylase, and there's going to be a lipase. So which one of these, we order the labs, we order some pancreas labs, amylase and lipase, and they come back. Amylase is elevated above normal, and lipase is elevated above normal. So what? Well, we know that amylase is not very sensitive and specific. Lipase is going to be more sensitive and specific than amylase. So let's say you have any sort of bowel problems, that could potentially cause an increase in your amylase. However, if you see an elevated lipase level, you're starting to think, oh, could this patient have pancreatitis? So then you're going to go to the clinical presentation. Do they have these symptoms? If so, then you may want to consider ordering imaging. Now, what's going to be the gold standard? It's going to be a CT. So an abdominal CT, that is going to be your initial screening with imaging. So now, there's a differential. You got to be thinking, well, what else could it be? Well, it could be cholecystitis. What about peptic ulcer disease? Either of these, I mean, epigastric pain, you got to be thinking, could be just a peptic ulcer. Cholecystitis or cholelithiasis or choledocholithiasis, could be any of those. You got to be thinking, well, yeah, maybe that might be more upper right quadrant. However, anatomy is not always the same on every person, so it could present mildly in the epigastric region as well. Could it be a small bowel obstruction? Small bowel obstruction, everything's plugged up, you got that pain. Could it be a hepatitis, for example? Can't spell. However, I mean, four things in your differential. Is that a complete list? No, but this is a good start on what to start to expect. Lots of causes, but there are two main ones. Board questions. So for the COMLEX, for the USMLE, both step 1, step 2, possibly even step 3, 2 number 1 causes. I know that doesn't make much sense, but we're going to go with it. 2 number 1 causes of pancreatitis. What are they? First one is going to be stones. Now I'm just going to back up a little bit. What happens at the ampulla vater if you have a stone obstructing that duct? So at the ampulla vater, going into the small intestine, the duodenum, what happens if you have a stone obstructing the flow? Well, you know that your bile duct isn't able to excrete, and you know that your pancreatic juices aren't able to excrete. So you'd be expecting maybe an elevated bilirubin. You'd be expecting liver enzymes to increase, so your transaminases. You'd also expect your lipase levels to be increased. So you gotta be thinking, is it a stone? What if it's not a stone? What if on your CT, what if on ultrasound, you don't see evidence of either gallstones or ductal stones? Then you gotta be thinking, well, what about a history of alcoholism? Alcohol is gonna be another main number 1 cause of pancreatitis. So, you know, in 18-year-olds, you're maybe thinking more stones. In a clinically presenting case, so for a board exam, you know board exams always have that paragraph, and that paragraph has a good clue. Well, you might see a 40 or a 50 or a 60-year-old gentleman who comes in with confusion and epigastric pain. You gotta be thinking, is he an alcoholic? So look at the presentation. Otherwise, just know alcohol is the number 1 cause of pancreatitis as well as stones. How do you treat it? Well, what we're going to be looking for is, number 1, fluids. Well, first make sure that they're stable. Make sure that their vital signs are stable, but then move to hydration. Hydration is going to be very important. Labs. One thing I can also throw up here, because I have run across it, what happens to your hematocrit? Your hematocrit in pancreatitis. So what's a good hematocrit change? Well, we're going to see it increase. Why do we see this hematocrit increase in pancreatitis? Well, in patients with pancreatitis, you're going to see dehydration. That's going to be related to our number 1 treatment. I mean, no, we're not going to go in and do surgery on them right away. We're going to hydrate them with fluids, massive, copious amounts of IV fluids. Now, before we give them fluids, we're going to see their hematocrit increase. And that's because they're going to be dehydrated, so, you know, the high normal, you might see it high normal. I mean, I've seen it at that, but it might also be 50 plus. Just kind of depends person to person, you know, the normal limits always vary. So if somebody's running low normal always, but all of a sudden they come in with a 48, 49, 50, then you still kind of need to be thinking it could be a pancreatitis, or they're severely dehydrated. Okay, so treatments. The number 1 treatment is going to be fluids. If they have a long-acting bout of pancreatitis, an acute flare-up that lasts days and days, they're not going to be eating, they're not going to be drinking, because that'll cause the severe pain, the severe nausea, the severe vomiting. So what you'll also need to do is probably insert an NG tube and consider feeding through the NG tube, bypass that duodenum so nothing gets released. This is an important step always, but the number 1 treatment is going to be fluids. Otherwise, it's just supportive care. If it's an infectious pancreatitis, there's a lot of different types. There's going to be infectious, necrotic, and there's a whole bunch of types of pancreatitis. I'm not going to cover that right now. However, if it's an infectious etiology, of course you're going to use some sort of antibiotic to treat the pancreatitis. Otherwise, it's mainly supportive care. Make sure their fluids are normal, make sure their vitals are normal, make sure their acute symptoms do not flare up. And then if it proceeds to a chronic pancreatitis, then you have other fish to fry, per se. However, for an acute flare-up of pancreatitis, this is what you really need to know.